like we have followed the same rule, that is we talk about the demand in the market, we talk about the supply in the market. So as far as the demand for physicians is concerned, what can you say about the demand for physicians? Now that you have taken so many classes in econ, what do you think? What characteristics can you state for the demand for physicians?
High.
Okay, why would you say it's high? And why would you say, you know, people demand physicians in the first place?
We're sick.
Okay.
To invest in their health stock.
Okay, so you are saying that basically the physicians, like any other healthcare product, they are inputs and you can use those inputs to build your health stock. Okay, so like any other healthcare product, just like you had for hospitals, the physicians are also inputs, and the demand for these physicians are generated because in the first place you want to build your stock of health. You want to improve your capital good, which is your health. Any other characteristics? So this is the first characteristic you have, is it's an input. So it's an input demand.
The hospitals.
And as soon, just a minute, and as soon as we say it's an input demand, we know that we are talking about a derived demand, right? Just what we explained right now. So we said that it's a derived demand. It means you demand physicians not because you just love going to a physician, but because you want to improve your health. So that drives your demand for a physician. Yes, Josh.
I was thinking like the hospitals, create a demand for them too, because the hospitals need the physicians to make money.
Okay. So how can we put that in the economic sense? How would you kind of rate a physician and a hospital? What is the connection? Are they related goods? Are they substitutes? They are complements, right? So sometimes the demand for the hospitals, the demand for hospital care will also drive the demand for physicians. So they are complements to each other. Similarly, the demand for substitutes or the lack of demand for substitutes can also drive the demand up for physicians. And who would be substitutes for physicians?
Nurse practitioners, CAs.
Who would be substitute for physicians?
Nurse practitioners.
Nurse practitioners, or even within the physicians, you may have substitutes like specialists and primary care physicians, right? So the demand for one group or the lack of demand for one group can drive up the demand for the other group, right? So it can be driven by related goods, both complements like hospitals, or substitutes, which could be nurse practitioners or another group of physicians within the physician community itself. Okay, anything else? Can you say anything about the elasticity of this demand? Is it going to be elastic?
Inelastic.
Inelastic, right? Like any other healthcare, it's going to be inelastic. What else? Can you say anything else? Is this going to be like the demand for any other good like ice cream? Is it going to be free flowing like in the competitive market? Or is it going to be induced?
They induce their own demand.
There is a possibility of induction of demand, right? Because of the principal agent problem which we have talked about. So there is asymmetric information. The physicians know more about your health. They have a better assessment of your medical assessment of your health than yourself. And I'm not talking about you guys in the class. You know more. So you are not in the traditional group of patients. But usually for a patient, that person does not have enough health information. So there will be a asymmetry of information between the physicians and the patients, so that there is a possibility that the physicians may be able to induce demand or drive up the demand. So there's a possibility of induction of demand or induced demand. Okay. So those are the characteristics. Broadly, we can say that these are the characteristics for demand of physicians, right? Now, when we talk about the other side, which is the supply side of physicians, what do you think we can say about the supply of physicians? Limited supply, right? Or there is compared to the demand, the supply is less, isn't it? So let's say, limited supply. Or in other words, we are saying that the quantity supplied is much less than the quantity demanded. So if you have a market like this, where the quantity supplied is less than the quantity demanded, what do you have in that market? You have a shortage. So the physician's market is characterized by large-scale shortage. Why in the first place do you think there is limited supply? What is it about physician's market that makes it different? And why do you think there is limited supply? Why don't we have a lot of physicians?
High cost of input to produce.
So can we put that in economic terms? Can we say that there are barriers to entry in this market? It's not a market where, you know, there is free entry of these people. There is no free entry of the sellers, because in the physician's market, the patients are the demanders, they are the buyers, and the physicians are the sellers, right? So while you have large number of buyers in this market, you have limited number of sellers. And the reason that you have limited number of sellers is because entry into this market is extremely restricted, or in other words, there are barriers to entry. Okay? So we can say that this market has barriers to entry.
Would you talk in terms of like monopolistic or anything like that?
We are getting
Oh,
there.
okay.
Okay? So barriers to entry. Now in the real world, what are these restrictions that we are talking about? What are these barriers?
Licensing, education.
Licenses, right?
Cost,
Not
education,
everybody
time.
can start tomorrow. If I say, okay, fine, I'm going to start practicing as a physician, I cannot. First, I have to have the essential degree, I have to have the essential education, I have to be in a residency program, maybe I have to do a couple of fellowships and all of that, and most importantly, I have to have a license, right? In other words, this market, in that sense, it is a restricted or a regulated market. And by regulated or restricted, I mean that you need permission or license to start being a seller in this market. So there are high costs. By barriers to entry, I also mean high costs. And by high costs, I'm referring to education costs. It is expensive to be a doctor, right? And licenses. Okay. What else do you think could be a reason for this shortage, specifically in United States,
Not enough schools to,
in the context of USA?
like the number of schools per, like, you can't just go train 50,000 doctors because there's not enough schools.
So there is lack of infrastructure. There are not enough schools. Okay, accepted. What else? Think from the other's perspective. If you have a shortage, what usually happens in another market? Let's say you are in the ice cream market. Okay, there are more demanders and there are less ice cream sellers in the market. Okay, so there will be shortage. Now, if that market has to be satisfied, if all customers have to be satisfied, if each one has to buy ice cream, what should happen in that market?
That they go buy their ice cream overseas. Like
Or
the
people,
physician.
or other way round,
You know what I mean?
yeah, other way round, that people from outside should come into that market.
Yeah.
More ice cream sellers have to come in,
Like bringing
right?
doctors from out of the country.
Exactly. So in this physician's market, more physicians need to come in. And if you're not producing enough physicians within your country, the other way that physicians can come in is cross borders, right? More physicians from other countries coming in, or in other words, immigrant physicians coming in. So that means the fact that this shortage has not got wiped out over time also has to do with stringent immigration policies, specifically policies that have prevented doctors from overseas to come in and start practicing. Okay, I know for a fact that in United States, at least in the 1950s and even in the early 1960s, doctors from outside could not come in and practice at all. The immigration policies were that stringent that even if you have a medical degree outside of USA, you cannot come and practice. Now that became a little flexible in 1965 when there was a reform of the immigration policies, but even then there were restrictions in terms of the immigrant doctors who had degrees outside of USA. Even then they had to come and get into a residency program, right? They had to do the residency, then do some fellowships, then take the exam for licensing, and finally start practicing. Now there is a good side to it and there's a bad side to it. The good side is quality control, of course, right? Education in another country may not have the same uniform code or the standard that is in USA. And for something like medicine, which is very hands-on, you do need quality control. Okay, so in a way that is good, but the negative side of that has been that this shortage has not got wiped out. Okay, so another reason for that is also restriction on immigration. Restriction on immigration. Okay, that has also been a reason for this. Now, while you have this shortage, now what do you think in a market where there is shortage, what do you expect to see in terms of prices? There will be increase, isn't it? There is less supply, remember? So that means this is a restricted supply, and whenever there is a restricted supply, there is a decrease in the quantity that is available and there is an increase in the price. So that is exactly the reason that the prices of physician services has been so high in United States. If you compare the prices of an office visit of USA with any other country, any other developed or less developed country, you will see it is significantly high in United States. And one basic reason for that being the shortage. Okay. Now, apart from that, apart from the prices being high, the other factor that has culminated from this shortage is also the returns. By returns, I mean how much a doctor earns. That has been extremely high. Because it is a product, it is a good or a service that is extreme, that has so much shortage, the people who can practice, they make a lot of money. Okay? But please note that these returns, so usually what happens, let's say in a market, we are talking about any other market. So this returns is something like, if you can think about it as revenue or profit, right? If we thought of these physicians as business firms, these returns would be whatever they earn, isn't it? Whatever these firms earn. So the earnings of the physicians, usually in any other market, in a competitive market, what would that do? That would bring in more people into the profession, isn't it? If it was a competitive market, because this high return would make this market extremely attractive, isn't it? And you know that in an attractive market, people come in from outside. But in this market, that is not possible because of the licensing requirements. So that's why although there is shortage and although this market, the existing people earn high returns, it is not possible for a lot of outsiders to come in, a lot of other physicians to come in and take advantage of that high return, and eventually that high return getting wiped out. That does not happen in that market, which otherwise would have happened in any other competitive market. Correct? Do you understand what I'm trying to say? Had it been a competitive market, then people would have come in from outside and wiped out those positive returns. Eventually, it would have got spread out. But now, people cannot come in from outside. Other physicians cannot come in. Other people cannot come and practice medicine due to these stringent licensing requirements. So these high returns for the doctors continues to exist in that market. Now, so the returns for the doctors have remained high. So it's a highly paid profession. So it is not just, so as when we talk about prices, it is not just that the consumers are paying a higher price for them, but the people themselves, the sellers themselves, the physicians themselves are also making a lot of money, and all because of this shortage. Okay? So if you put this in a demand-supply diagram, now this should be pretty simple for you guys. You know how to put this in a diagram. So had this been a free market, had this been a competitive market, that would have been the equilibrium of the market, that would have been the quantity, and that would have been the price, right? But now you have a large-scale shortage. So you have the supply pushed back right there, so that you have less quantity, and you have a higher price in the market. So as simple as that. Okay, so we're not going into that. What we're trying to say is it's more than the competitive market. So now also think about the service that is provided. Do you think this is homogeneous? Is it homogeneous service in the physicians market? Not really. Physicians, once again, there may be a lot of difference in terms of location. There may be a lot of difference in terms of, the quality of service that is provided. A physician who is graduating from a very good medical school, let's say Harvard Medical School, and has 10 different fellowships and has a lot of experience, and he has been working in hospitals in the metropolitan cities, having a lot of exposure, may have more skill set and hence may be able to deliver a better quality service than some other physician, right? So it is not homogeneous. Do you understand? You know for your own program, one of the USPs of your program is that they give you a lot of clinical practice, right? So that sets you apart from people who are pursuing the same degree as you in some other school. They don't get as much clinical exposure as you. So hopefully your quality of service is going to be better than somebody else who graduates with the same degree as you from some other university. Same thing for the physicians. So you also see that this is a market where it is heterogeneous. Now, given all these qualities, what do you think? Is this market going to be competitive, perfectly competitive? Closer to what? Which market structure? Monopolistic competition, right? Like the hospital industry. It is unlikely that it is going to be perfectly competitive. Rather, it's going to be monopolistic competition. Now, in monopolistic competition, is competition totally wiped out? In a monopolistic competitive market, is competition totally wiped out? No, right? Otherwise, we wouldn't call it monopolistic competition. That competition word would not be there had competition been zero in that market. But in a monopolistic competitive market, what kind of competition do you have? Think from your hospital chapter. Do you have price competition? You have quality competition, isn't it? It's not so much price competition. Also think in terms of the physicians market. Even in the physicians market, the physicians do not really compete in terms of price. One physician, you do not go to a physician because that physician says, okay, you know what, I'm charging $5,000 less for a surgery. You go to a physician because of his reputation, and that reputation comes in terms of the non-price factors, the qualitative factors, right? So that means even in the physician's market, just like the hospital market, you have non-price competition. It is monopolistic competition, which means competition is not zero, but that competition is not price competition, rather it is non-price competition or qualitative competition. Okay, so you still have competition in this market. But it is non-price competition. So now we have non-price competition in this market, and this is a monopolistic competitive market and all of that. But what could be done, or what has been done in United States to kind of cure this problem of shortage? Because this is a very serious problem, right? It is driving up the healthcare costs of the people, and there is one group of people in society, these physicians, who are making exorbitant amount of money. So there are other social costs of that. Okay, so what has been done to kind of cure this problem of shortage? One, of course, is like bringing in immigrant doctors, so relaxing the immigration policy, and that has worked to a certain extent. But we have seen that these immigrant doctors who have come in, it has been seen, it has been observed empirically that these immigrant doctors have mostly catered to the shortage in the market for primary physicians, the primary care. cities, I don't know how much it is true in Springfield, but in big cities, for example, I've seen in Atlanta and I've seen in San Antonio and I've seen a little bit in Boston, that if you go to an urgent care clinic, most of the doctors there are immigrant doctors. They have degree from Romania or they have degree from some other country, and they are primary care physicians who have degrees from outside who are immigrant doctors. That means that the relaxation of the immigration policy over time, this has helped to cure shortage, but it has only helped to a certain extent in terms of primary care physicians. But in terms of specialists, you still have a very high shortage. Because these immigrant doctors, usually they would come and they would specialize in things like internal medicine or geriatrics. They would not do, a lot of those acute care kind of specializations. Okay? So the shortage has still remained in the specialty fields, and it has been somewhat mitigated. I'm not saying completely. It has been somewhat mitigated in the physician's care market. So the bottom line is that the immigration policy, the relaxation of the immigration policy has not been able to take care of this big shortage that we have in United States for physicians. Okay? So that means going forward, something needs to be done to kind of cure that shortage, at least at the discussion level. We don't know if all of that will happen because these things don't happen overnight, but here we are just discussing what needs to be done theoretically. So whenever there is shortage, what needs to be done? Think in terms of the discussion that we had for organ donation. There was shortage, right, in the organs market. So what had to be done to kind of trigger people, to influence people?
Incentivize the supply side.
Incentive, the incentive mechanism. So similarly here in the physicians market, if you have to cure this problem of shortage, there has to be incentives given so that that shortage can be taken care of. So there has to be incentives. Okay. And that is exactly what is being done right now to provide incentives to the physicians so that they can enter this market. Now these incentives can be divided into a couple of groups. The first incentives are the economic incentives. The next is the incentive from the insurance industry. And thirdly, we just have one general category, that is other incentives. Okay. Now when we talk about the economic incentives, we are specifically talking about two kinds of incentives here. Firstly, the incentives in terms of policies related to loans. These are, by economic incentives, we're basically talking about policy related incentives. What policies have the government taken to incentivize the physicians from entering this market, the young doctors to come into this market? What incentives has been given and hence cure that shortage? The first one being low interest loans or deferring of payments on loans. Okay, so if you want to study medicine, you can get low interest loans. You can defer the payment on your loans. That is something that has been done in USA. In some cases, there has been absolute waiving. There has been waiver of loans provided you are ready to go to an underserved area. If you go to a remote place, that's why if you go to North Dakota, or maybe you go to South Dakota, or you go to Idaho, your loans can be kind of remitted or waived. Okay, that is also there. The third policy which has helped in incentivizing doctors is also the changes in the fee structure of Medicare. changes in the fee structure of Medicare, which means now, if you remember, the customary fee system has come up in the Medicare, right? So if you provide this kind of service, you will get this reimbursement for the Medicare patients. If you serve a Medicare patient and you provide this service, a certain service, then no matter where you are serving the patient, or what kind of qualification you have, you will get a customary fee for that service. So in other words, there is kind of the price is being made uniform, the price is being made structured, which is also kind of reducing the earnings gap between a specialist and a primary care physicians, or between different primary care physicians. That is also an incentive. Earlier, if this is not there, then as a physician, I have less incentive, because I would think that, okay, maybe another doctor will be able to make more money than me, right? He will be able, if he's more competitive in whatever way, if he's qualitatively better than me, he will be able to make more money than me. So that is a kind of a disincentive for me. But now if I know that by rule, by policy, everyone in the market, or most people in the market, will fall under a standard reimbursement plan, then that's an incentive for me to be in the market or come into the market. So changes in the payment structure within the Medicare, changes in the fee structure within the Medicare system has also helped or incentivized physicians to come into the market, and it has also helped in reducing the earnings gap between the different categories of physicians. Okay? As far as the incentives from the insurance industry is concerned, we are specifically talking about the expansion of managed care organizations. How do you think the managed care environment will incentivize physicians and hence cure the shortage? Why would managed care environment be an incentive for physicians? What happens in managed care?
Patients channeled to them. They get patients channeled to them.
They get patients channeled to them, but how would that shortage be kind of eliminated?
Gatekeepers?
You need more primary care physicians, right? So there are more primary care physicians. The penetration of managed care organization helps in recruitment of more primary care physicians, and that most of the patients get catered to at the primary care physician level. So once again, the role of the specialized doctors, the specialty doctors, gets reduced somewhat, because you have these gatekeeper physicians who are primary care physicians. And what did we say? We said that if there is less restriction on immigration, if there are doctors coming in from outside, those doctors are somewhat mitigating the problem of shortage in terms of primary care physician. So if you already have many people who are serving as primary care physician, and simultaneously you have an expansion of these managed care environment, then that means most of the patient needs, or at least a large part of patient needs, is getting served at that level. And patients are not getting as much bothered by the shortage at the specialty care level or the specialized doctors level. Okay? So to some extent, I'm not saying completely, but to some extent, the expansion of managed care organization has also helped in removing this shortage, or helping in reducing the earnings gap between the primary care physicians and the specialty doctors. Now, among other incentives, you have the policies like which are basically the public run programs. So there are programs which are designed specifically by several state governments and the federal government, which just give so much incentive to the doctors, and those incentives could be in terms of tax credits, those incentives could be in terms of higher income, those incentives could be in terms of remittance on education loan. And they are just said that if you start practicing, and you start practicing in a certain geographical area, or you cater to patients of a certain economic group, or you cater to patients of a certain racial group, then you will be given these incentives. Okay? That has also kind of helped in mitigating this shortage, because most of this shortage that we have seen in United States, it is not so much in the urban areas. Most of this shortage kind of comes from the underserved areas of USA. Okay, so by giving these incentives, we have seen that empirically the shortage is being taken care of somewhat, but the bottom line is, you know, it is nowhere close to being bridged. It is nowhere close to being wiped out yet.